a really interesting and important topic. And I was saying to Robert a little bit earlier, I've got two of these sessions. One that I'm doing. One of them is around, in fact, menopause, but I've taken the liberty of broadening out a little bit. And then the other one is about men with PBC, and they were things I've never done a talk on, and yet they're really important issues. So I think it's something that's really interesting and important. And this is something that's come very much to our fore in terms of our thinking. So I'm very pleased to talk about this. It did seem sensible to just broaden it to include other questions we get asked all the time about HRT, the pill, pregnancy, etc., with PBC. So hopefully it's interesting. Okay. So just some observations, when I was pulling all this together. I don't have to tell you these things are really important, but there is almost no discussion of them at all in clinical guidelines. It's like it doesn't exist. They don't get talked about in textbooks of hepatology. They don't get talked about in guidelines. And actually, I went through some of the PBC Foundation literature, and we don't talk about them very much. So I think there's a real gap in terms of what we do. There is also a lot of speculation on the internet about this. So you can find a lot of things that are said with all the confidence that things on the internet often do, but there is actually very little data. And what data there are suggests that the speculation in the internet is largely wrong. So one of the reasons why we're going to really increase our amount of sort of content about this is that it's an area where there is enormous misinformation. So I'm going to pick off a few questions that are relevant to all of this, and we'll finish up with menopause and HRT. So the first question, and these are kind of through the life cycle. So the first one is, does the oral contraceptive pill cause PBC? And why might we think this? Well, one of the reasons is that people often don't have PBC until they're found to have PBC when they have a pill check. And so therefore there's an association. But remember what I said before about association and causation? You need to make sure that it isn't just you've happened to notice it. The other real reason is that, of course, estrogen and progesterone in other situations can cause cholestasis, the process you see in PBC. So they can alter bile flow. PBC is a disease of bile flow alteration, ergo they must be linked. There's also the association between cholestasis and pregnancy. So people can get itch and abnormal liver blood tests and cholestasis in pregnancy. And then our old friend, the internet, has a lot of speculation about the pill. So the first of these urban myths, if you like, the pill causes PBC. Does it or does it not? Well, the answer is absolutely not. Absolutely not. There is a very good study done by Christophe Corpachet from Paris, which looked at 200 plus PBC patients and 500 matched controls. And what they showed is that pill users, in fact, were less likely to get PBC than non-pill users, less likely. So the pill does not cause PBC, full stop. Simple. I'm not going to talk. We're not going to talk about this. We could set you an exam at the end, and we can talk about the various different pathways. The reason for showing this is to make the important point that estrogen and progesterone are highly linked into the function of the liver because they are very close cousins of bile acids. They're both based on cholesterol. And so abnormalities that give rise to cholesterol change can also give rise to hormone changes. So there is a biological link. It's just that in terms of actual clinical events, there is no association between the pill and PBC. Although, like I said, the data are reasonably limited. So conclusions about that: limited data for PBC, estrogen, progesterone metabolites can sometimes interfere with pathways of bile acid homeostasis. That's why you get these problems sometimes. The thing that we were talking about a little bit before about genetic background is also likely to be very relevant. So there will be a susceptibility about this. But in red is the important point that we make to clinicians, is that if women have successfully and safely taken oral contraceptives without problems in the past, they will not have problems in the future. And so people can use it with confidence. And of course, there are other forms of contraception, and it's always a balance of what the right thing is for individuals. So the pill causing PBC is basically an urban myth. Now, liver disease and pregnancy. So let's move on in the life cycle to pregnancy. What about PBC and pregnancy? Well, here we have to split the disease into the two types I mentioned before, the very small minority of people with cirrhosis and the large majority of people without cirrhosis. So anybody who has cirrhosis of any cause, pregnancy, particularly late pregnancy, can cause one or two issues to do with varices development, blood vessels in the gullet. And the reason being is because of the physical pressure inside the tummy. So towards the end of pregnancy, pressures can go up in the veins and people can have bleeds. So anybody who's cirrhotic gets an endoscopy around about the end of the second trimester. Okay, so about 24 weeks or so, 24 to 30 weeks, we'll get an endoscopy. But this is a tiny number of people, a tiny, tiny number of people, because cirrhosis is actually very rare in PBC these days, and certainly in younger patients. So that is an important caveat. I don't want to talk about that anymore. In terms of liver disease in pregnancy, there are now very good clinical guidelines. So if anybody you know falls pregnant with PBC, they should be directing their doctor to these European Association of the Liver guidelines, which tell people absolutely everything that you need to know. And in general, PBC patients tolerate pregnancy very well indeed, with no worsening of the disease at all and no particular problems with it. So in many ways, one of the most awful consultations I ever had was with a woman in her mid-40s whose biggest regret in life was not having children because her doctor told her it was too dangerous to have children with PBC. She had stage 1 disease, okay? And this is the sort of madness that gets out there. So pregnancy is tolerated very well with no particular problems, but just watch out for the very small percentage of people with cirrhosis. Now, one question that crops up all the time, not about the risk of the disease, but what about the risk of the drugs? So, what about drugs? And apologies, this is very small, but what about the sorts of drugs you use in PBC? Are they safe in pregnancy? Are they safe for the father to take? And should you use them whilst you're breastfeeding? Those are very important questions. And one of the things that's really important in all of this is that we always use a precautionary principle. So in fact, for many drugs, we simply don't know because we never use them because we avoid drugs. And that's important. So for most drugs, there is simply no evidence of whether they're safe or not, and whether you can take them. But we tend to want to avoid them. Now, the exceptions to that is ursodeoxycholic acid, where there is extensive data that it is safe in pregnancy. And the recommendation for practice is to continue urso throughout pregnancy. We know it's safe in pregnancy because it's actually used to manage cholestasis in pregnancy. So urso is very simple and straightforward. We recommend that people continue it. What about the other drugs? Well, fibrates, there is some evidence that they may be not good in pregnancy. So we would always advise discontinuing bezafibrate. And obeticholic acid, we simply don't know at all about it. And therefore we would tend to avoid it. Now, I mentioned about the nasty little shock that you can get with MMF around COVID. Well, its other nasty little shock is that it is teratogenic. It will cause malformations in babies, and it's an absolute no-no to continue on MMF for anybody who wants to get pregnant. Absolutely written in tablets of stone. So, in practical terms, avoid bezafibrate, avoid OCA. Okay to continue with urso. And these are the guidelines that just explains exactly that. So urso can continue. Strangely enough, one thing that always surprises people in terms of itch. So if itch were to get worse in pregnancy, cholestyramine is safe, but we all know the limitations of that. But ironically, one of the drugs that is known to be very safe and is used in pregnancy is rifampicin. So that's also used sometimes in cholestasis of pregnancy. So our first choice treatment for anybody with really intractable itch during pregnancy would actually be rifampicin. Okay. So conclusions about this, limited data specifically about PBC, a gloriously sort of tautological statement, but it's a summary of what we are. No evidence to indicate that urso is not safe to continue. And on that basis, we should continue it. And it's reasonable to use fibrates perhaps very late in the disease, but not earlier than that. Rifampicin could be useful. There is just one observation with it, which is that um, bile acid levels themselves can be associated with risk to the pregnancy. This is what happens with cholestasis of pregnancy. So one of the issues with that is that very occasionally you can have stillbirths with it. And that's why people are delivered earlier if they get cholestasis in pregnancy. It may be that the same thing applies. And so I think one of the things that's coming along now is the suggestion that everybody with PBC who is pregnant gets their bile acid levels measured relatively early in the pregnancy, and that be watched on a serial basis, and earlier delivery if bile acids are very elevated. But I have, in my entire career, never seen anybody with PBC who was pregnant with elevated bile acids. But it's probably, we want to avoid any problems ever occurring. So what about menopause and HRT? So there are two reasons why HRT might be used in the menopause. And one of them is an old reason, which is not such a good reason anymore. And one is a very important reason. And I'll just get rid of the old reason first, which is osteoporosis. Now, when we talk about HRT and menopause, we are talking about, if you like, the physiological menopause, the change in life. We are not talking about the menopause that happens in anybody who has their ovaries removed surgically. Okay, in that situation, clearly replacement therapy is always appropriate. So it's replacing a physiological gap. This is natural menopause, if you like. And one of the reasons why people used to get HRT is because of osteoporosis. Okay, which is common in women. It increases in frequency as age increases, and it's made worse by the cholestasis of PBC because you have problems with vitamin D. So we're very live to this. And I said before, the average of 9 fractures in people going to have a transplanted PBC 30 years ago. But as I also said, we don't see this anymore as a significant problem. And that's because of the way in which we treat this. So osteoporosis in PBC is much less of a problem than it was before because of various different factors, including URSO. And if it does develop, it is much better treated by other drugs like the bisphosphonates, so Fosamax and drugs like that. So there is no reason at all in 2023 to use HRT as the primary treatment for osteoporosis in postmenopausal women. It is not the best and safest and most logical drug. So there are some people where this is still done. It's probably not best practice. So the first point about menopause and HRT is don't give HRT if the only indication is for osteoporosis. Now, what about the biggie, which is the symptoms of the menopause and their interrelationship with the symptoms of PBC? And I suspect when we're talking about menopause and asked to think about it, this is the thing that everyone is asking us. Okay, so why might there be a connection? Well, brain fog is a commonly reported feature of the menopause in all populations, and 40% of PBC patients will report brain fog. And those of you who've heard me talk will know that there's been a huge amount of research on this as an important problem and as a target for therapy. So it's a very logical thing to think that there is a link between these. And of course, 90% of PBC patients are female. The average age of diagnosis in the UK is about 55. So you can see why you might think the two are linked. So is brain fog in PBC therefore actually menopausal symptoms misattributed as PBC? And the answer is no, for two reasons. The first is brain fog also occurs in men with PBC. Okay, so it occurs in men. It's not going to be menopause in them. And then the other is that actually, per head of the population that is affected, brain fog is commoner and more severe in premenopausal women than menopausal. So it occurs in groups who are not menopausal women. So therefore, it can't be the only explanation. However, One of the things that we do, people will be familiar that we've developed a whole new clinic to look at the symptoms of PBC, and that has been a real eye opener in terms of the impacts and the issues. And it's one of the reasons why I now feel that we had probably misunderstood the importance of all of this, and that kind of led to the various different things that we're now doing, and this talk, and thinking about this much more. And the reason is that the approach that we take is to take all of the problems that contribute to the way people are and address those problems in a serial way. So I don't think we can say in any individual patient with PBC who's menopausal, is it the menopause, is it PBC, or is it both? The answer, I suspect, is that it's an additive effect. And what we should be looking to do is to treat all of those components of that total, and not miss any chance of making it better. So the point is, I think HRT and the menopause, I think the menopause is a contributor to the clinical burden of a lot of PBC patients with brain fog, although I don't think the menopausal symptoms are worse in PBC patients per se. I think it's an additive effect. But, and it's a really important but, I suspect menopausal brain fog is going to end up being easier to treat than PBC brain fog. And for that reason, I think HRT is something we're going to increasingly need to think about. So I think it is a combination effect. So the $64 million question, is HRT safe in PBC or not? And in thinking about this, I think there are two aspects to consider. The first is, does HRT make PBC worse? And rather like the pill and pregnancy, there's a logic to that, given the postulated cholestasis link. So, are you going to make PBC worse with HRT? And then the flip side of that is the other risks that people think about with HRT, in particular cancer risk and clotting. Are those more likely to be problematic in PBC patients? So, are you increasing other forms of risk? And I think many of the decisions about HRT non-use in particular are snap decisions made by doctors without considering the actual evidence in all of this. And I'll show you the reason why I think that's the case. So these are reasonable questions. They are reasonable questions, but the answers are not as obvious as people think they are. So short answer is no. Actually, Robert, I've just given a short answer. I've just given a short answer, Robert. I answer my own question with the word no. So, to do what I normally do, which is to then make this all a lot more complicated, does HRT make PBC worse? No, it doesn't. And there are two studies that have looked at this. And these are trials that looked at patch-based HRT, and irrespective of anything else, we do recommend using patch estrogen because it reduces what's called first pass exposure. So a patch, the estrogen gets into the circulation, has its effects around the body, without giving the liver a high level of exposure. But if you take a tablet, then most of the estrogen that gets up into the portal vein actually is broken down by the liver. So the liver is exposed to a very high level. So it is a much more physiological way of doing it. And so the strong recommendation from us, it's not in guidelines, is to use patch-based therapy. And we sometimes get blowback from the GPs about that, but that is our strong recommendation. So this is a trial, and it looks at, on the left, the reasons why people stopped taking patch HRT, and on the right is changes in blood tests. Okay, so on the left, nobody stopped taking HRT in this trial. Nobody stopped because they had a worsening of their liver disease. So that didn't happen at all. On the right, there is no clear pattern of worsening of liver function tests. Now, at the bottom, the HRT bilirubin change, you'll see there is a steep slope at the top. That is somebody whose bilirubin is 50 at the beginning. That nowadays in 2023 would be a reason to start thinking about liver transplant. So that is somebody you wouldn't dream of using these sorts of approaches in, but this was nearly 20 years ago. So with the exception of people with very advanced disease, where there was a single person, there is no evidence of a signal at all. The other study Very similar, again, patch estrogen, only 18 people, but these are the trials that are out there. Patch estrogen, and on the right, you can see the blood test, the bilirubin, the ALT, the alkaline phosphatase, the albumin. The orange is people with the patch HRT, the black is people without HRT, and there is absolutely no difference at all in liver function tests. So there is no evidence at all that HRT, if it started, makes PBC worse. Now, what about the thing that everyone worries about with HRT, which is cancer and clotting risk? So cancer and PBC is probably the biggest source of urban myths of anything. And there is a particularly terrible paper which came from a very famous group in London, which says here are 12 patients with PBC who got breast cancer. And it was responsible for the scare that breast cancer is common in PBC patients. 12 patients, all of whom had PBC and breast cancer. Now, obviously, that's total nonsense because PBC is a disease that particularly affects women, and breast cancer is unfortunately common in the population. If you took another paper that showed that prostate cancer was almost never seen in PBC, you wouldn't use that to argue that PBC was protective against prostate cancer. You'd say, but PBC men don't get PBC as commonly. So it's one of these, gosh, aren't there a lot, without any attempt to understand whether that's a level you would or wouldn't expect. You're going to see PBC patients with breast cancer because the disease affects women in their 50s. The question is, do they see more? And the answer is they actually see less. So this is actually some of our work from Newcastle from a long time ago now, which looked at a case control study of PBC and cancer. So what this does is take a large group of PBC patients, 700 plus, and it compared them to the ordinary population, same age and gender. So it's a like for like comparison, which is the only way that you can do it. Okay. And what you then look at is whether a cancer is commoner or less common in PBC compared to the ordinary population. On the left is the frequency, on the right is the frequency with which people died of it. Okay, so if you look at this, so that the SIR is a standardized incidence rate, it's a ratio. So PBC patients got exactly the same rate of breast cancer as non-PBC patients. The incidence ratio was 1. The reproductive tract cancers, ovarian and uterine, was a little bit above 1, but that is not significant. So there is no association between PBC and breast cancer, uterine cancer and ovarian cancer. And if you look at mortality, actually PBC patients were less likely to die of breast cancer than non-PBC patients, less likely. Reproductive cancer, a similar thing, very slightly elevated, but not significant. So if the concern is around HRT and a cancer risk, a PBC patient taking HRT would have exactly the same increase or otherwise in cancer risk with HRT that somebody without PBC would have. That's not to say HRT is safe in PBC and doesn't cause cancers. I'm not the right person to discuss the evidence on that. All I can say is in the discussion about HRT and cancer, the PBC is an irrelevant factor. It is not a co-risk factor. And what about DVT? Well, it's the one thing in all of this we literally have no data. So thrombosis, people are aware of with HRT. Do you get more in the way of DVTs with PBC? I do not know. All I know is I haven't admitted anybody with a DVT in PBC for years and years and years. So there isn't, if anything is there, it's not a screaming risk. So what about PBC, the menopause and HRT? The same caveat, the data is a bit limited. And I think we actually need to take this really seriously. And I think, bless Davina, she's pointed out to the ants and decks of this world, like me, that we don't know enough about it and don't take it seriously enough. And that's a fair call. A lot of speculation, misinformation on the web. There is no evidence or clinical experience to suggest HRT makes PBC worse. I've never stopped HRT in somebody because I was worried about their liver getting worse with it. There is no objective evidence or clinical experience to suggest that reproductive or breast cancer or DVT are common in PBC versus non-PBC. And our view, therefore, is that HRT should be used in PBC if otherwise clinically indicated. And the large clinical indication is around brain fog management, where I feel it's an important part of the package of management. And I think that's the last slide. So I hope that's been useful. I think the exercise is very important because it shows us what we don't know. But the bottom line here is that in essence, pregnancy, pill use, and HRT are all safe in PBC, and the menopausal symptoms are likely to contribute to the total symptom burden. And I can foresee ourselves using far more in the way of HRT than we have done until this point. And for that, I will thank Davina.
Okay, perfect. Thank you very much. Couple of questions, if I may. So the first one is, what can you do if your clinician is determined to put your symptoms down to menopause and not down to PBC?
So anyone, I mean, we come across this all the time where people have got more than one clinical problem that's associated with fatigue. Come across this all the time. And I also come across doctors who seem to have magic eyes because they can always tell that it's the other disease that causes the symptom, not the disease that they're managing. They have magic eyes. I don't have magic eyes. We said this about long COVID. Again, it's a really interesting thing, is that there are certain ways in which the body responds to certain situations. So, in a sense, muscle fatigue happens for lots of different reasons, but the sensations are the same, a little bit like itches. And so it can ultimately be very difficult indeed to dissect it out to the extent that it's impossible. I certainly can't. So what we do in the clinic is we approach it from the completely different direction. So we're about to launch a kind of data set for clinicians, for nurses, about how to approach symptoms in a structured way. If you like, turning our clinic into something that any clinic can run. And we call it My 3 Steps, which is to identify the 3 things in anyone that we can proactively do to improve symptoms. So it's a philosophy of how you approach it, okay? And it's to make the point that actually there are steps you need to take. There's no magic answer, and there's no magic bullet to all of this. But the concept is you start with where you want to go, and then you try and work back to all of the things that mean you're not there. So don't start with how somebody is this menopause, is this PBC? I can work out which it is. No, start with what you can't do on a day-to-day basis and the problems that you get, and then you look at why that happens physiologically in terms of how the body works, and then you look at correcting anything and everything that might cause it. So a classic example is the commonest treatable cause of fatigue and PBC is low thyroid function, right? It's not part of PBC. PBC patients get hypothyroidism. So anybody with PBC fatigue, you check the thyroid, because that's a really easy thing to do, and no clinician can tell the difference between thyroid fatigue and PBC fatigue. I can't. So what you do is you check their thyroid function. So you start with the problem, and you don't start with the disease and work to the problem. You start with the problem and work back to the causes. And what you then do is treat all the treatable things. So if the clinician is saying, is this all menopausal symptoms, then the answer is try HRT and find out if those symptoms go away. It doesn't even mean you need to take it for any long period of time. It's almost as a little therapeutic test. If it's HRT, if it's menopausal symptoms, get back with HRT. And so therefore, it isn't PBC. If it doesn't improve with HRT, it's PBC. So having a stale argument of is it PBC or is it is it menopause is going to be very difficult. I would treat the treatable and then see what is left at the end of it all. I think a therapeutic trial of HRT in that setting is the way I would go. In general, I hate it when doctors end up in these rather stupid and facile, debates about the reality of this, that, and the other, and all of those things. It's no good for you. It's no good for them. And 9 times out of 10, they end up with egg on their face.
Yeah.
I mentioned about the various different legal cases, and what you see throughout is this constant thread of the same mistakes being made again and again and again, with people doubling down on it at every single stage. And it's almost as if people just don't feel able to say, do you know what, let's have a think about that again and maybe see whether we're right or not. And I don't know, I mean, some of these things are just awful, and you think, why did you do that?
No,
It's
it's fair.
bad. So don't end up in a debate. Treat what's treatable, see what's left, and that will give you the answer.
Thank you. Should females ask for regular cholesterol tests, particularly post-menopause?
So I think everyone with PBC should have their cholesterol checked, because cholesterol is complicated in PBC. So it's naturally elevated as part of the disruption. So bile acids are made out of cholesterol. So cholesterol metabolism is very much affected by it. The problem is, in terms of understanding it, is that most of the cholesterol elevation is the good cholesterol. So the total cholesterol number is nowhere near as useful as it is in other situations. So a value of 10 doesn't really mean anything. It will be very high in other settings, but in PBC, it may be entirely harmless, or it may be unsafe. PBC doesn't protect you against getting high risk cholesterol. So you've got family history of heart disease and high cholesterol. Having PBC won't protect you, but just having a high cholesterol value doesn't automatically mean that you're going to need treatment. So everyone with PBC should have their cholesterol checked and do a cholesterol split. And how frequently you do that will slightly depend on what the baseline value is like. And if you've got an elevated high risk cholesterol, then we would recommend treating it as you would in everybody else. If necessary, statins are perfectly safe in PBC.
Perfect. Thank you. Yeah, please. Follow-up question.
Yeah. 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 Yeah.
Can cause an elevated cholesterol level. And we're just in this quite time where he doesn't know enough about it. I don't know enough about it. So we're
So the question for Dave is where the patient has high levels of cholesterol. I was repeating this for the people that are online. High levels of cholesterol, but the GP is not entirely sure about PBC, so doesn't know what he's doing with that. And the patient's not really confident or knowledgeable enough to present a cohesive argument. So what do you think could be a potential solution there?
So there are 2 answers. There's a kind of correct answer and there's a pragmatic answer. So the correct answer is that ask the GP what your HDL cholesterol is, okay? And they will, and if they say, how do you know about HDL cholesterol? Or technically it's non-LDL cholesterol, okay? So if you need to know the split, okay? And that will trigger them, because they're just they're not organizing the right test, okay? So yeah. So basically, you've got a total cholesterol and you've got an HDL, okay? And basically, you want to look at what percentage of the total cholesterol, so what percentage of the elevation comes from the HDL and what comes from the others, and you'll get all of that from the app, okay? So this is for you to make your own decision. So you can get that information provided the blood test has actually been done. They don't always do a cholesterol split. That's what you need to do. We would never do a straight cholesterol measurement ever, because there is no point in PBC unless you know the different constituent ones. The cop-out answer is, why not take a statin rather than end up in a debate about it? So statins have been a major advance in terms of cardiac risk. I take a statin. So you could argue, cholesterol's elevated. The trials of statin showed that cholesterol elevation per se is associated with cardiac risk, and reduction per se is associated with cardiac risk. So there's a danger we're asking a slightly more sophisticated question. So the counter argument would be, why not just take a statin? Nobody wants to have a heart attack. I think that the nuanced version of that, and I don't want to get into the details of your medical history, but if there's a family history, more likely to take a statin. If you smoke, you need to stop smoking, more likely to take a statin. If you've got nobody with a cardiac history and you don't smoke, and the cholesterol is only a little bit elevated and it's not, it's HDL, you don't take a statin. But I think in general, it's not a stupid thing to do in those situations. I personally would think that the health service is benefited by doing a simple and cheap test to work out whether you actually need it rather than a lifelong treatment. But, others would see it differently. In terms of side effects of statin, again, I think it's a very tiresome debate. You can get muscle ache with it. There's no doubt about that. I got muscle ache when I started it. You reduce the dose a little bit and it's less of a problem. So I think if in doubt, I would flip it around and say, why not take it? Because, they really are very safe and effective drugs.
Perfect. Thank you. Very last question for today.
Yeah.
Thank you so much. Any studies, investigations, links with obstetric cholestasis or intrahepatic cholestasis in pregnancy? I'll let you define that. And PBC, and in terms of best practice, in terms of on it goes. A nice, easy one to finish.
So it's a really good question. So ICP, idiopathic cholestasis of pregnancy, is a condition where you develop cholestasis in pregnancy. You develop the blood tests become abnormal, the alkaline phosphatase go up, and people often develop itch. Okay, so it looks, sounds, and feels like a quite rapid form of PBC. The reason it's really important is twofold. One is you can feel quite miserable towards the end of pregnancy with the itch. So, it's a pretty horrible thing, but it's self-limited. It goes away when you have the baby. And then the other, as I mentioned before, it will cause stillbirth because the bile acids poison the baby's heart. And so we have I try and use these memorable memes for the fellows so that they remember things. And my teaching thing about cholestasis of pregnancy is there are 3 steps to the management of cholestasis in pregnancy. Once you've diagnosed it, it's deliver the baby, and deliver the baby. Okay, so it's well managed by getting to 36 plus weeks and then delivering the baby, and all of the problems then melt away. There has been a question around for years: does that predispose to getting PBC later? And there are several answers to that, the short one of which is yes, but only a little bit. The reason it's complicated is a number of people who had cholestasis in pregnancy and then who went on to develop PBC actually probably had PBC in pregnancy. And it was put down because cholestasis of pregnancy is a diagnosis of exclusion, if you like. It doesn't have its own diagnostic tests. It's, somebody who's cholestatic in pregnancy, sometimes people will be labeled as that without any investigations. So that definitely does happen, but I think there is some evidence that there is an association. It's probably genetic, and it's probably to do with the role that bile flow abnormalities play in the development of PBC. So I think if people have had cholestasis in pregnancy, then it's worth factoring it in, and I might get my liver blood test checked every 5 years or so, just to be certain about it. But it is not, the vast majority of PBC patients have not had cholestasis in pregnancy. The vast majority of people who have cholestasis in pregnancy do not develop PBC, but you probably do see more than you ought to of people who do.
Wonderful. Thank you very much. Ladies and gents, Dave.